Can you hear me? Yes. Okay, Mamuka. So yes, we want to present the second patient. And first, again, congratulations to your outstanding team. You have really great nurses, great anesthesiologists. Everything is running smoothly. So I'm very happy to be here. So this is now a patient. I think she is 74 years old, and she had COVID. And after COVID, she experienced several symptoms. She had headache, she had some discomfort, but then she also experienced abdominal pain in the left side after food. She lost 20 kilograms, so everybody was a little bit afraid. But now, when I talked to the patient, and she gained already weight. So this is an important information for us. And for the moment, she is doing fine. The pain also diminished. It's not that strong at the beginning. So a computer tomography and an MRI was performed, and there the patient has now a cyst in the pancreatic head. And when we have this situation, we have to check the cyst first by MRI, because the MRI and the MRCP gives a very good overview, anatomical overview about the pancreatic duct and the relation of the cyst to the pancreatic duct. And in the second step, we will perform now endoscopic ultrasound, see the structures of this cyst, if there are nodules, if there are calcifications, etc. And then we have to make a suggestion for the patient what to do. Because the cyst is in the pancreatic head area, I first perform now assessment of the papillary area using the duodenoscope, because we need the information if this patient has a Fischmau papilla. So what I'm doing now, I think we need the suction. I'm using now the Olympus GGF 160 duodenoscope. The pylorus should be at 6 o'clock position, so I'm now in the duodenum. I'm careful forwarding the endoscope. So now, this is very important information. Patient has a duodenal diverticulum, which is relatively large. And here we see the papilla. So what I'm doing now, I'm checking the papillary orifice, and I'm insufflating a little bit air and desufflating. And what you may appreciate, there is no opening of the pancreatic duct. There's no mucus coming out. We have here this large diverticulum, so this is a little bit dangerous examination, because we have to be careful with insufflation of CO2. So I'm always trying to suck out the air. And then I'm also checking in the area of the minor papilla. I think here on the side you can nicely appreciate there is a minor papilla. Okay, so the first question is answered. I'm removing this scope now. And then we will come back with the echo endoscope. Okay, here in the area of the pancreatic head, on the left side you see the portal vein. And here is now the cystic tumor. So first we would like to measure this cystic tumor. So freeze, please, freeze. Okay, and now we measure. So the tumor is less than 3 centimeters. It's about 25 by 1.5 centimeters. And what we are going to do now is, okay, please. I would finish, yes, okay. And now I'm checking now the structure of this cyst. What you can see on the right side, we have an isolated cyst, but within the cyst there is no calcification, and there's also no nodule. And when you look here at the left side, there are multiple cysts, and there are a lot of septae. So these septae are a little bit echo-rich, but every cyst by itself has no calcification and no nodules. So this is a very important information. So now I think we will check for the pancreatic duct and the bile duct, and I pushed in the scope a little bit, so I think on the top you can nicely appreciate the bile duct, and down there's the pancreatic duct. Now we are using Doppler, and you nicely appreciate this is the bile duct, and a little bit more deep down there is the pancreatic duct. And stop please, freeze. And now we measure the bile duct, here to here. Okay. So the bile duct is 5.6 millimeter, so it's not dilated. And now we are measuring the pancreatic duct. A little bit. Yeah. Okay. Okay, this is 1.6. Okay. And now what I'm going to do is I'm trying to trace now the pancreatic duct into the direction of the cyst. And here you can nicely appreciate. Do you have a file or something to show? Wait a moment. The cursor. Enlarge. So what I want to show is, there must be a, wait a moment. Okay, wait a moment. What I'm going to show now, I will move the scope. This is the pancreatic duct, and then you will see that there is a connection here to this cyst. So please focus now on this. So you see here, this is the pancreatic duct, or a side branch entering the cystic structure. So I think this is a sign that it is a side branch IPMN. What I have to admit is now that when we look at the material inside the cyst, it's a little bit echo-rich, but as I mentioned before, there is no really, so freeze. So here we have the impression that it is a little bit more bright. So I think this is a little bit mucus. Okay, defreeze. So I think the conclusion is now that we have a side branch IPMN. We also see here nicely, freeze again. Can we move a little bit? Again, defreeze. So we also see here again down pancreatic duct coming up. You see at 6 o'clock we have pancreatic duct. I torque the scope and the duct has connection to the cyst. It's we can very nicely see this here. Okay, so this is the cyst now, but now the next question is, it is important also to check the pancreatic tail and the pancreatic corpus, and this we are doing from the duodenum. Okay, I'm retracting this, I'm withdrawing the scope into the stomach, and I try to find pancreatic tissue. Here we can nicely appreciate this is the left adrenal, and here is pancreatic tissue. And so this is the pancreatic tail. So with the sector technology, I always have to torque the scope 180 degrees to always have a full overview of this level I'm. With the radial endoscope, this is different. There you have a better overview. But with this technology, you have to go step by step. You go to a level and you torque the scope always 180 degrees, and then you are sure that you have visualized the whole level. So this is the pancreatic tail, and what is interesting now for us is how large is the pancreatic duct. Please freeze. And now measure from here. This is the pancreatic duct, and we will measure it now. Okay, move again. No, yeah. Okay, measure. So one more, and you see, no. Only this here. So the duct is only 1 millimeter in the pancreatic tail. So this is very important information for us. So we have no Fischmar papilla and we have no dilatation of the pancreatic duct. So this is a typical side branch IPMN without involvement of the main pancreatic duct. And for this tumor, the guidelines are very clear. If the lesion is not exceeding 4 centimeters, we don't need to do anything. I'm checking now the pancreas also for other lesions. So now I'm pushing the scope in. This is the portal vein system, and make smaller. And this is an interesting position here from the stomach, I can also visualize the pancreatic head. So here's pancreatic head, and here's pancreatic corpus and tail. So I'm pushing the scope in a little bit, but the pancreas looks fine. And now I'm trying to go again into the pylorus.
You are checking the pancreas ecogenicy, right?
Yes, I'm checking the ecogenicy, and I also am looking for other cysts, because many patients who have IPMN, they also have more cysts in the pancreas. So I'm forwarding the scope again to the duodenal bulb. Now we are in the pancreatic head area. Here we have our IPMN. This here is the bile duct, which is not dilated. We have the pancreatic duct, and I think we will push the scope in a little bit more.
He doesn't have a mural of the push, right?
I beg your pardon?
No mural road, right?
No. This is another cyst. Wait a minute. I'm pushing in the scope again. So here we have freeze. We have another cyst. Now this. Here we have another cyst, but here it appears that around this cyst, the tissue looks a little bit thicker. Freeze. So here that looks a little bit more dense, you know. Okay, we freeze. So I think what we are going to do now is we will try to puncture this area here. Not the cyst, but I'm trying to get material out of this dense area here.
Pancreas can be said, right? Is that tumor outward or?
No, I will try to get the outward here.
Outward.
Yes. Okay, so this is the 20. So we are using now, so for the pancreas, there are a lot of discussion what needle you should use. In most of the cases, 22 gauge needle is recommended. But in this case, I will take a 25 gauge needle because the position is not so optimal because I'm relatively deep inside, and the advantage is the smaller the needle, the more maneuverability I will have. But she also has the, yes, wait a minute. Go back first. So now I'm introducing first the needle, and the problem is here we have a complicated position, so the scope has to be straightened. Now I'm checking the needle, so the needle is out, so I'm pushing the needle a little bit back. Now I fix the needle, and now I try to find again this specific area. This was here. Yes, right now. Okay, freeze. And decrease? Okay. Okay. One smaller, yes. Okay. Freeze, freeze. So it is somehow here, this area. Here. It's about 4 centimeters. Okay. I think the radiologist is in the room. Maybe you can ask him, Mamuka, how large for him was the lesion in the MRI. And we have now the problem with the EOS. We have not such a good overview. So the radiologist can tell us how large his impression was of the cystic lesion. So we had this upper part, which looked like typical IPMN. But here, this area, I don't know what the radiologist had for an impression. And we, for sure, we also have diverticulum in there, no? Need okay? The problem is always coming down. Maybe this is some pancreas and also the So I think this is a very interesting case. I have forwarded the endoscope very deeply, and we had the impression that this is also a cystic area of the pancreas, but what we can now visualize is, I think this is the right kidney. The problem is the left kidney we can visualize very well, but the right kidney is very deep for us, and I have forwarded the scope very deep. So I think this is here the kidney, and the question to the radiologist is if the patient also has kidney cysts. So now I'm retracting the scope. There we have again the cyst, and this is the bile duct again. And here we have this lesion. But when we push the scope very deep in to assess the uncinate process, we are coming here in the cystic area. And I think this is, in this patient, the kidney. That's okay. Okay. The point is, I think it's IPMN, but we had cysts very deep, and I think these are cysts from the kidney. Okay. I'm pretty sure that this is the kidney because I'm pushing the scope very much in, and this is, you see the echo-rich structures, and I think this is the kidney, so we will check this. And when I'm retracting the scope, I'm at the level again now at the papilla. There we have pancreatic duct, bile duct, and we have here in the pancreatic head area, we have this IPMN. So this IPMN I would not puncture because there is no nodule structure. And we have also seen that there is no dilatation of the pancreatic duct. So I think we can clearly conclude that this is a side branch IPMN, and from the guidelines, patient needed follow-up once per year by MRI, and if there is an increase of the cystic structure or we have dilation of the pancreatic duct, we have some so-called worrisome features, and in this case we would repeat the EOS to get some tissue, but at the moment there's no need to puncture this cystic structure because we have a risk of infection, and also the sensitivity of detecting anything in a cystic lesion is very low. That's why it makes no sense to puncture this patient. Okay, so if you have questions to the case, then let me know.